There is a particular kind of conversation that happens in medicine, not during the appointment, but after it, in the hallway, between colleagues, over coffee at a conference. It is the conversation where doctors stop speaking the way they speak to patients and start speaking the way they speak to each other. And one of the subjects that comes up in that quieter, more candid space, with more frequency than most men over 60 would ever suspect, is the question of what certain nutrients actually do to a prostate under pressure. I want to have that conversation with you today. My name is Dr. Naira Stein, and I work as a seniors health and wellness consultant. If you are navigating questions about prostate health, whether you have received a concerning result, whether a family member has asked you to look into this, or whether you are simply the kind of person who wants to understand what is happening inside your body before a problem arrives at the door, I am glad you are here. Stay with me through this conversation. It is one of the most practically useful things you may hear about this particular aspect of your health, and I promise to speak to you plainly and honestly throughout. What I want to share today concerns 3 nutrients. Not a supplement protocol, not a pharmaceutical workaround, 3 specific compounds, 2 of them found in ordinary foods, 1 of them generated by your own body under the right conditions, that the research literature consistently links to meaningful protection of prostate tissue in the aging male body. They are discussed carefully and with genuine respect in medical and research circles. They are rarely discussed in the detail they deserve with the men who need them most. Let us change that. Understanding what happens to the prostate after 60. A small gland with an outsized role. Before we arrive at the nutrients themselves, I want to make sure you understand the landscape we are working within. Because the prostate does not simply sit there passively, it is an active, hormonally responsive gland, and the changes it undergoes in the 6th, 7th, and 8th decades of life are not random. They follow patterns. They have mechanisms. And once you understand those mechanisms, the relevance of specific nutrients becomes not just plausible, but biologically logical. The prostate is a walnut-shaped gland that wraps around the urethra, the tube through which urine exits the body, just below the bladder. In younger men, it weighs roughly 20 grams and carries out its primary function, producing the fluid that carries sperm during ejaculation. That is its job, and in the first 4 decades of life, it tends to do that job quietly and without incident. After 50, and with increasing consistency after 60, several things begin to shift simultaneously. The hormonal environment changes, and the prostate feels it. The first and most significant shift is hormonal. Testosterone, the primary male sex hormone, declines gradually from around the age of 30 onwards. This is well known. What is less discussed is what happens to the ratio of testosterone to estrogen as a man ages. Estrogen, which is present in men at lower levels throughout life, does not decline at the same rate as testosterone. In fact, the balance tips steadily in estrogen's direction as the decades pass, and estrogen, acting on prostate tissue, promotes cellular growth. Simultaneously, an enzyme called 5-alpha reductase converts testosterone into a considerably more potent compound called dihydrotestosterone, commonly abbreviated as DHT. DHT binds to prostate tissue with an affinity roughly 5 times greater than testosterone itself, and it is the primary driver of the cellular proliferation that produces benign prostatic hyperplasia, the enlargement that causes so many men over 60 to find themselves waking 2 or 3 times each night, standing at the bathroom for longer than they used to, or feeling that the flow that once came easily now requires effort. This is benign enlargement, not cancer. But the same hormonal environment that drives benign enlargement also creates the conditions in which other, more serious changes become more likely. The prostate in an older man is a gland under sustained hormonal and inflammatory pressure. Inflammation, the factor most men are never told about. The second major force acting on the aging prostate is chronic low-grade inflammation. This is the factor I want to spend a moment on because it is the one most consistently underemphasized in standard conversations about prostate health, and it is the one most directly connected to the nutrients we are going to discuss. Chronic inflammation in the prostate, sometimes called prostatitis, though it exists on a spectrum far beyond the acute infection that name implies, creates a cellular environment that is persistently irritated, persistently in repair mode, and persistently generating the kind of oxidative stress that damages DNA in cells over time. Cells that are repeatedly cycling through damage and repair, under oxidative pressure, accumulate the kinds of molecular errors that, over years and decades, increase the probability of malignant transformation. The relationship between chronic prostate inflammation and prostate cancer is one of the more extensively documented connections in urological oncology. It is not a certainty, it is a probability gradient, and the steeper the inflammatory environment, the steeper that gradient becomes. Here is what matters most about this. The inflammatory environment of the prostate is modifiable, not perfectly, not completely, but meaningfully, and specific nutrients play specific, mechanistically understood roles in that modification. This is where the quietly held medical conversation becomes the one I want to have with you directly. Why certain nutrients rarely make it into the room. The gap between research and the appointment. There is a real and documented gap between what the nutritional and urological research literature says about prostate protective compounds and what actually gets communicated to men during a standard clinical appointment. This is not a conspiracy. It is a structural reality of how medicine is practiced under time pressure. A urologist managing a patient with elevated PSA, a recent biopsy result, or active urinary symptoms is working through a clinical decision tree that is appropriately focused on diagnosis, staging, and treatment. The 15 minutes available are consumed by those urgent priorities. The conversation about long-term nutritional support for prostate tissue rarely has a home in that appointment, not because the physician doesn't know the research, but because the appointment is not designed to accommodate it. What this means is that many men over 60 are managing their prostate health in a state of partial information. They know about PSA testing. They may know about Flomax or dutasteride if their urologist has prescribed them. They know, vaguely, that certain foods are supposed to be good for the prostate. What they often do not have is a mechanistic understanding of why specific compounds protect prostate tissue, at what level of intake that protection becomes meaningful, and how those compounds interact with the biological processes already underway in their gland. That is what I want to give you now. The first nutrient, zinc and its critical role in prostate chemistry. What zinc does that nothing else does. The first nutrient I want to discuss is zinc. And I want to be specific about why, because the story of zinc and the prostate is genuinely remarkable, and it is not the version most people have heard. The healthy prostate contains more zinc per gram of tissue than almost any other organ in the human body. This is not incidental. The prostate actively concentrates zinc from the bloodstream at levels roughly 10 times higher than surrounding tissues. This extraordinary accumulation is not a quirk of anatomy. It is a functional requirement. The prostate uses zinc to perform specific biochemical tasks that are essential to its normal cellular regulation, tasks that, when zinc becomes insufficient, begin to fail in ways that carry direct consequences for cancer risk. The most important of these tasks involves a process called citrate accumulation. Normal, healthy prostate cells store large quantities of citrate, a compound involved in cellular energy metabolism, rather than oxidizing it for energy the way most other cells do. This unusual metabolic behavior is maintained by zinc. Zinc suppresses the activity of an enzyme called mitochondrial aconitase, effectively putting a brake on the pathway that would otherwise consume the citrate. When zinc levels in prostate cells are adequate, citrate accumulates as it should. When zinc levels drop, as they do in malignant prostate tissue, that brake is released. The enzyme becomes active. Citrate is metabolized, and the cell shifts from the energy pattern of a normal prostate cell to the energy pattern of a cancer cell. This is not a theoretical observation. Studies examining zinc concentrations in prostate tissue have found that malignant prostate cells contain dramatically lower zinc than normal prostate cells, sometimes up to 80% less. The relationship is consistent and reproducible across multiple research populations. Whether zinc depletion is a cause of malignant transformation, a consequence of it, or a bidirectional amplifier is still being examined. But the correlation between prostate zinc levels and cellular health is one of the most robust findings in prostate cancer biology. What happens to zinc after 60? The difficulty is this. Zinc status in older men is frequently compromised for reasons that have nothing to do with poor dietary choices. Zinc absorption in the gut decreases with age as gastric acid production declines. Certain medications that are common in the over 60 population, including proton pump inhibitors for acid reflux, thiazide diuretics for blood pressure, and some ACE inhibitors, either reduce zinc absorption or increase its excretion through the kidneys. Alcohol consumption, even at moderate levels, increases urinary zinc loss. And diets that are lower in red meat and shellfish, which many older adults are correctly eating less of for cardiovascular reasons, tend to reduce the highest bioavailability dietary zinc sources. The result is that a meaningful proportion of men over 60 who believe they are eating reasonably well are walking around with marginal zinc status, not deficient in the way that would register as a clinical emergency, but insufficient to maintain the prostate tissue zinc concentrations that support normal cellular function. How to address zinc through food? The dietary zinc sources with the highest bioavailability, meaning the forms most efficiently absorbed, are animal-based. Oysters are by a significant margin the richest source available, containing more zinc per serving than any other food on the human menu. 3 ounces of cooked oysters typically provide several times the recommended daily intake. This is not a practical everyday food for most people, but 2 or 3 servings per week is both realistic and impactful. Beef and lamb, particularly the darker, more iron-rich cuts, are reliable everyday sources. Pumpkin seeds are the most bioavailable plant-based option, providing around 10 milligrams of zinc per 100 grams. Hemp seeds and pine nuts follow. Legumes, lentils, chickpeas, black beans, contain zinc in forms that are less readily absorbed due to the presence of phytates, though soaking and sprouting before cooking meaningfully improves their zinc availability. The practical target for prostate protective zinc intake in older men is in the range of 11 to 15 milligrams per day from food. Higher is not better. Chronic excess zinc intake, particularly from supplements, can actually suppress immune function and create copper imbalance. The goal is adequacy, consistent and maintained through food rather than through high-dose supplementation, unless a clinician has identified documented deficiency warranting therapeutic correction. If you have not had your zinc status evaluated recently, it is a straightforward blood test worth requesting. In the context of active prostate health monitoring, knowing your zinc status provides clinically useful information that is routinely overlooked. The second nutrient, lycopene and the architecture of prostate cell protection. The compound that travels directly to prostate tissue. Lycopene is a carotenoid, the red pigment that gives tomatoes, watermelon, pink grapefruit, and guava their characteristic color. It is one of the most studied phytonutrients in the context of prostate health, and the volume and consistency of the research connecting lycopene intake to reduced prostate cancer risk makes it one of the more convincing examples of food-based prostate protection in the medical literature. What makes lycopene particularly relevant to a conversation specifically about the prostate is its tissue distribution. Carotenoids circulate in the body and are taken up by various tissues, but the prostate accumulates lycopene preferentially, concentrating it from the bloodstream at levels higher than most other organs. This preferential accumulation is not fully understood mechanistically, but the biological outcome is clear. The prostate is actively interested in lycopene, and when dietary intake is adequate, prostate tissue maintains meaningful lycopene concentrations. Those concentrations matter because lycopene is one of the most potent antioxidants found in human tissue, with the capacity to quench a particularly damaging form of reactive oxygen species called singlet oxygen at rates significantly higher than other well-known antioxidants, including beta-carotene and vitamin E. In the context of the chronically inflamed prostate, generating persistent oxidative stress, accumulating DNA damage at the cellular level, lycopene provides a direct, tissue-targeted antioxidant presence that reduces the oxidative burden on prostate cells. It is worth being honest that not every study examining lycopene supplements has replicated the findings associated with dietary lycopene from food. This is a consistent pattern in nutritional research. Whole food sources frequently outperform isolated extracts, likely because the matrix of compounds in which lycopene naturally occurs contributes to its absorption, metabolism, and bioavailability in ways that isolated supplements do not replicate. The detail that transforms the tomato from salad to medicine. Here is the practical detail that most people who have heard about lycopene and tomatoes do not know. And it is the difference between eating tomatoes and actually getting meaningful lycopene from them. Raw tomatoes provide lycopene in a form that is poorly absorbed by the gut. The lycopene in a fresh, uncooked tomato is embedded in protein structures within the cell wall that limit how much the digestive system can extract. Heat processing, cooking, concentrating, pureeing, breaks down those cell wall structures and releases lycopene into a far more bioavailable form. Cooked tomato products, therefore, provide substantially more absorbable lycopene per serving than the same weight of raw tomato. Tomato paste is the most concentrated and bioavailable source available in a standard kitchen. 2 tablespoons of tomato paste contain more absorbable lycopene than several whole raw tomatoes. The second crucial detail is that lycopene is fat-soluble. It requires dietary fat present in the same meal to be absorbed efficiently through the intestinal wall. Tomato sauce cooked in olive oil, a genuinely traditional Mediterranean preparation, is not a coincidental pairing. It is nutritionally optimal. The olive oil dramatically enhances the absorption of the lycopene from the tomatoes. A plate of pasta with a tomato olive oil sauce, eaten regularly, delivers lycopene to prostate tissue in a form and quantity that a plate of tomato slices cannot match. The practical target is 4 to 5 servings per week of cooked tomato products, always prepared with a healthy fat. This is achievable without any meaningful lifestyle disruption. Tomato sauce on pasta or grains, tomato-based soups, shakshuka, tomato paste stirred into stews or grain dishes, all of these count. The habit of having cooked tomatoes with fat several times weekly is one of the most practically accessible and evidence-supported things a man over 60 can do to support prostate tissue health through nutrition. The third nutrient, vitamin D and the regulation of prostate cell growth. The hormone your body makes from sunlight, and runs short of after 60. The third nutrient in this conversation sits in an unusual category because vitamin D operates biologically not as a vitamin in the traditional sense, but as a steroid hormone. It is produced in the skin when ultraviolet B radiation from sunlight converts a cholesterol precursor into a compound that the liver and kidneys then activate into the biologically potent form, calcitriol. And calcitriol does something in prostate tissue that is quietly extraordinary and that most men have never been told about. Prostate cells contain vitamin D receptors, significant concentrations of them. The activation of those receptors by calcitriol triggers a cascade of effects inside the cell that directly counteract the proliferative, inflammatory environment that promotes both benign enlargement and malignant transformation. Specifically, calcitriol suppresses the activity of inflammatory pathways inside prostate cells, including the cyclooxygenase 2 pathway, which is one of the major producers of pro-inflammatory compounds in the gland. It promotes what is called cellular differentiation, pushing cells toward their mature, specialized, normal identity, rather than allowing them to remain in the undifferentiated, proliferative state that characterizes early malignant development. And it directly induces apoptosis, the programmed self-destruction of abnormal or damaged cells in prostate cancer cell lines. A cell that receives adequate vitamin D signaling is a cell that is being steered toward normal behavior and away from unchecked growth. The epidemic deficiency in the population most at risk. Here is the problem. Vitamin D deficiency in men over 60 is not a fringe concern. It is a widespread and largely undetected reality in the populations where prostate cancer rates are highest. Vitamin D production from sunlight declines significantly with age because the skin's capacity to synthesize the precursor compound diminishes across the decades. A 70-year-old man exposed to the same amount of sunlight as a 25-year-old produces roughly 25% of the vitamin D that his younger counterpart generates from the same exposure. Indoor occupations and lifestyles, which characterize the majority of older adults in developed countries, further reduce sun exposure. And geographic latitude plays a significant role. In temperate and northern climates, the sun's angle from October through March is insufficient to trigger meaningful cutaneous vitamin D synthesis, regardless of time spent outdoors. Dietary vitamin D is found in fatty fish, egg yolks, and certain fortified foods, but in concentrations that, under realistic eating patterns, are rarely sufficient to compensate for the production shortfall created by limited sun exposure. The result is that blood levels of vitamin D in the deficient or insufficient range are found in a very large proportion of men over 60, in some populations, the majority. And the relationship between vitamin D insufficiency and prostate cancer risk has been examined across dozens of studies. For men who are deficient or insufficient, supplementation under physician guidance is the most direct correction. Vitamin D3, the cholecalciferol form, is the form best supported by evidence. The appropriate dose varies considerably by baseline status, body size, and latitude, and it is worth having a conversation with your physician about your specific numbers rather than self-prescribing. The toxicity ceiling for vitamin D is real and needs respect. It is a fat-soluble compound that accumulates rather than clearing quickly, and chronic oversupplementation produces hypercalcemia with serious consequences. How these three nutrients work together. Synergy is not incidental. I want to take a moment to draw these three nutrients together because there is something important about how they relate to each other that matters beyond their individual actions. Zinc operates at the cellular metabolism level, maintaining the citrate accumulation pattern that distinguishes normal prostate cells from malignant ones, and supporting the hundreds of enzyme systems throughout the body that perform quality control on cellular replication. Lycopene operates at the oxidative stress level, reducing the DNA damage load in prostate tissue, and through its anti-inflammatory effects, moderating the chronic inflammatory environment that creates the conditions for malignant change. Vitamin D operates at the regulatory level, influencing the genetic programs within prostate cells that determine whether they differentiate normally, proliferate uncontrolled, or trigger their own programmed death when they accumulate enough damage to become dangerous. These are three distinct mechanisms acting at three distinct points in the biology of prostate cell health. They are not redundant, they are complementary. A prostate tissue environment that has adequate zinc, meaningful lycopene presence, and sufficient vitamin D signaling is one in which the three most well-documented pathways of prostate cancer development, metabolic shift, oxidative DNA damage, and failure of cellular growth regulation, are all being addressed simultaneously. This is not a guarantee. Cancer is a complex disease with genetic, environmental, and stochastic components that no dietary intervention controls completely. What nutrition provides is probability management, reducing the steepness of the risk gradient, creating a cellular environment that is more resistant to the insults that drive malignant transformation. For a disease where the gap between early-stage survival rates and late-stage survival rates is as wide as it is in prostate cancer, even modest probability management, applied consistently across years, carries meaningful weight. The men who need this most are the ones who hear it least. There is a particular irony in the way prostate health information reaches the men most affected by it. Younger men, for whom prostate cancer risk is largely theoretical, encounter it in the abstract. Older men, those over 60, those with family history, those already managing elevated PSA or a previous biopsy, often receive their information from appointments focused on active management of a detected concern, rather than from a broader conversation about the nutritional environment in which their prostate exists. The three nutrients described in this conversation are not a substitute for active medical monitoring. They do not replace PSA testing or follow-up biopsies, or the treatment conversations that must happen when those results warrant it. What they represent is the layer of proactive support that sits alongside medical monitoring, the daily choices about food and nutrient status that are shaping the tissue environment inside the prostate right now, today, regardless of what the most recent blood result showed. You have more influence over that environment than you may have been led to believe. Not infinite influence, but real, biologically grounded, research-supported influence. And exercising it begins with three things: making sure your zinc intake is consistent and adequate, building cooked tomato products with healthy fat into your regular eating pattern, and knowing your vitamin D level well enough to correct it if it is insufficient. I want to close the substantive portion of this conversation with a practical framework, because information without application is of limited use. Let me be direct about what each of these three nutrients looks like in practice. For zinc, the priority is consistency over quantity. Identify the 2 or 3 zinc-rich foods you are most likely to eat regularly. Pumpkin seeds as a daily handful alongside other snacks. Red meat 2 or 3 times per week from lean cuts like sirloin or leg of lamb. Shellfish when available and affordable. If you are taking any medication known to deplete zinc, proton pump inhibitors are the most common, ask your physician whether zinc status monitoring makes sense in your case. For lycopene, the discipline is specificity. Raw tomatoes do not count in any meaningful way. The habit you are building is cooked tomato products with fat multiple times per week. Tomato paste is the most potent and practical option. 2 tablespoons into a sauce, a soup, or a grain dish. Standard tomato-based pasta sauce cooked in olive oil is nutritionally ideal. If you eat eggs in the morning, adding tomato paste or cooked tomato to that meal is a simple, habitual combination that provides lycopene alongside protein and fat in a single preparation. For vitamin D, the first step is knowing your number. Request a 25-hydroxy vitamin D test at your next appointment or as a standalone check. If the result comes back below 30, and particularly if it comes back below 20, discuss with your physician what correction looks like for your specific situation. Meanwhile, eat fatty fish. 2 servings of salmon, sardines, or mackerel per week is achievable and represents the most meaningful food-based contribution to vitamin D alongside whatever sunlight your geography and lifestyle make realistic. There is a question I am asked more often than almost any other in conversations about prostate health. Why is this not being discussed more openly? I think the honest answer is that it is being discussed. In research journals, at urology conferences, in the quieter conversations between colleagues. What is not happening consistently is the translation of that discussion into the language of practical guidance for the men who are living with this reality in their bodies every day. That translation is what this conversation has been. Not a promise that 3 nutrients will solve a complex biological problem. Not an invitation to abandon medical care in favor of a handful of pumpkin seeds. An honest account of what the evidence shows about 3 compounds that the prostate requires, that the aging male body increasingly struggles to maintain at adequate levels, and that carry genuine biological relevance to the 2 outcomes most men over 60 care about most: avoiding the development of serious prostate disease and managing what is already present as wisely as possible. You have heard the research, you know the mechanisms, you know what the prostate is doing with zinc, with lycopene, with vitamin D. You know that these 3 things are connected not arbitrarily, but through the specific biology of how prostate cells age, accumulate damage, and either recover their normal function or lose it. What you do with that knowledge, in the kitchen and in the conversation with your physician, is entirely in your hands. I am Dr. Naira Stein. This information is offered in the spirit of education, not as a substitute for personal medical advice, and never as a replacement for the monitoring and care your own physician provides. Every man's prostate health history is individual. Bring what you have learned here as a specific, informed question to the doctor who knows your numbers. That conversation, armed with understanding rather than vague concern, is the most productive clinical appointment you can have. The prostate that is being protected is not a theoretical organ. It is yours, and the daily choices that shape its cellular environment are already being made, with or without this understanding. I hope today they are being made with a little more of it. Take good care of yourself. I will see you in the next one.